One is our teaching lecture, and the other is our Advances in Urologic Oncology, which is really a system-wide effort that we do twice a month. That's kind of a CME event. So this nicely fits together with both themes. Today, we're really lucky to have Dr. Sia Daneshmand join us from the University of Southern California. Sia is a professor of urologic oncology in the clinical scholar track at USC. And, you know, I've been fortunate, many of us have worked with Sia. I think I've known you now for, gosh, about 10 years. And he really is kind of a rare person in urologic oncology, a role model for many of us as we've sort of tried to develop on this track. I mean, everything that I've heard is that, you know, Sia is just sort of a gifted surgeon, but there's so few people who can marry that with a career in translational research. And then I've seen him interact with his mentees, and he could just an outstanding mentor. So thank you so much, Sia, for giving us this little bit of your time. And we really look forward to hearing what you have to say. Thank you again.
Thank you, Josh, for that very, very warm welcome. Hopefully everyone can hear me okay and see the screen. Yeah, all good. All right, thank you so much. This is one of my favorite topics to speak about. I think germ cell tumors are fascinating, young patients, a lot at stake, and also so many nuances to treatment that we are continually learning. So I've got a lot to cover. I am from LA. I've been living here for a long time, although I was in Oregon for 6 years. Yep. I think, Michael, you may want to tend to your kids. But so I like surgery, and I serve on the AUA guidelines committee on testis cancer. So I want to break this down into stage 1, stage 2.
Since we're both on call, we should take separate cars.
To A and B.
Tell Haley we're. Well, I guess Haley's not gonna be here for a while.
No, I'm not on call.
You're not on
Michael,
call today.
maybe
Okay.
You can mute your computer or phone. There you go. All right. So so stage 1, basically, I'm not going to get into stage 1 management because I think most of us agree nowadays that management should be surveillance for both non-seminomas and seminomas with excellent cure rates, and almost certainly most of the patients, even when they relapse with stage 1 disease, are readily cured with either surgery or chemotherapy. So that's a lecture in and of its own, but I really want to concentrate more on sort of the stage 2A and B and beyond. Again, stage 1. One nuance with stage 1 is I've seen people sort of prognosticate people when they do relapse. When you do relapse as a 2 or 3 or whatever you do relapse, your prognosis is what we quoted you from the beginning. It's still 99% cure rate. So you don't re-prognosticate them when they present with 2. When you look at these large stage 1 series, they include all the people who then relapsed and got treated. So those survival rates with 99% are from that. So don't restage patients or reprognosticate them when they do relapse, and tell them, you know, now they have a 90% chance of cure because they relapsed. So RPLND in stage 2A, germ cell tumors in general. For non-Sems, we've known that RPLND has been a treatment option for decades now, really 70–80% cure rate without any further adjuvant chemotherapy. So I'm a real big proponent for surgery in 2A non-seminomas. And there's ample data to show, and we're going to there's going to be a presentation at ASCO coming up showing the long-term side effects of chemotherapy using the Norwegian database. So both chemo and radiation therapy are associated with long-term side effects. And so, you know, long time ago, I started thinking, you know, we do RPLND for stage 1 for stage 2 non-seminomas. Why don't we do it for seminomas? It makes no sense to me. And so we started thinking about this. Now, this is 2018. I just wanted to show you this, that patients, when you give them a survey, like, would you enroll in a clinical trial? And Nick Cost did this from Colorado. Most patients were willing to enroll in a clinical trial to look at the alternative therapies for low volume clinical stage 2 seminoma. So we actually had already opened up our trial by then. This was the Sems trial, which you may have heard about. This is the surgery in early metastatic seminoma. just presented the 2-year results at GU ASCO, and I'm getting ready to finally write the manuscript and getting all the data together. But multi-institutional study, as you may know, the management of stage 2A seminoma really hasn't changed in decades. The primary treatment recommendation has been either radiation therapy or primary chemotherapy with 3 cycles of BEP or 4 of EP, and then follow-up. So that's the NCCN guidelines. That's what we know. That's what's in our books. But wait a minute. So we treat a tiny little 2-centimeter seminoma recurrence in the retroperitoneum the same way we would treat someone with stage 1 non-SEM who recurred, with 10 different nodules in their lungs and big mass in the retroperitoneum. It just didn't make sense to me. So I thought, well, we do it in non-SEM, why don't we do it in seminoma? So cure rates are excellent, but there's long-term morbidity, as we talked about. These are these are young patients, years of potential cumulative toxicities, metabolic syndromes, infertility, neurotoxicity, and so on and so forth. So is there a treatment that can reduce long-term morbidity? And it really requires this change in paradigm, thinking about non-SEM versus SEM, and it really simple concept, really. RPLND, again, has known efficacy in stage 1 and stage 2 non-SEM. There's plenty of data. So basically, we just went to treating metastatic seminomas, limited metastatic seminomas with surgery. And we first started with, preliminary data. We had 4 patients that I had done, ranging in size from 1.1 centimeter to one patient that had a 5.5 centimeter mass. We just couldn't get a diagnosis. We tried biopsying the mass twice. The testicle had a burnt out primary. We couldn't really get a diagnosis. So finally, I just said that I'll remove the mass. It turned out to be a seminoma, and the patient was disease-free and remained disease-free for the rest of his follow-up. Which is now in his 8th year. So this was the first, 4 patients. And it turns out I wasn't, and dissection planes were normal. At the time, our length of stay was three days. This was early on in 2011 through 14. And we had 1 claving grade 1 ileus, all maintained antegrade ejaculation and no further therapy. The publication had 2-year follow-up, but I just saw my first patient for 10-year follow-up. He's disease-free, so he's out. Well, I wasn't the first to do this. There were some other authors who'd done this before. There were a few stage 2A seminomas in the literature that's our series with Brian, who was our fellow, who's now at Loma Linda, and the co-PI on this trial with me. So when you look at RPLND, in these 15 patients total in the world literature that we could find, there was 0 recurrence rate, very small subset, obviously, but radiation, you can see in chemotherapy is still associated with some recurrences. So here's the Sems trial. Basically, the primary outcome was 2-year recurrence-free survival, with secondary outcome of 5-year RFS and the pathological upstaging, treatment-free survival, and complications from surgery. We did have some surgeon requirements. We wanted this to be done at high volume centers. So the surgeon requirement was at least 8 open RPLNDs in 1 year or 24 in 3 years. The surgeon template, we said at least a modified template, but really it was up to the surgeon in terms of choosing the template. Intraoperative photographs had to be taken, just like the SWOG S1011 trial, just to make sure we have some quality control for the surgeries, and all were done to be done open. The reason being, you don't want to add another variable. This is such a tight statistical trial that one or two recurrences on one side will shift it. So you want to minimize all the variables around the trial. It opened in various sites around the country, as you can see here, but there were several that were high volume accruers, like you can see here, obviously us and Indiana University, but many contributed to the trial. And you can see the accrual that accrued quite well and closed about 8 months earlier than anticipated, which, as Josh can tell you from running clinical trials, is a major success for a trial. So it was great. I mean, we're all urologists. We like to do surgery, so it's good to have a clinical trial that involves surgery. Here's the basic characteristics of the patient. Importantly, 25% had stage 1 who then had a recurrence, and then 75% of them were stage 2A or B at presentation. And the median follow-up was 24 months, but obviously we have patients who are far out from that. For the manuscript, I will have minimum follow-up at 24 months for all patients. So nothing's changed. So at USC, and I'll get into this a little bit later, the patients are undergoing a midline extraperitoneal RPLND. The hospital stay is 1 day at USC, and this is the typical scar. Now, they don't all look like this, but this is obviously nerve sparing technique. But I'll show you the technique a little bit later as we talk about the surgical techniques. But the overall recurrence rate was 20% with a median time to recurrence of 8 months. So these are happening early during the follow-up, and the 2-year recurrence-free survival was 84%. And here's the breakdown of the secondary treatment. So 9 patients had chemotherapy. 7 of them were BEP times 3, 1 was EP times 4, 1 patient got carboplatin, and 2 patients had repeat RPLNDs. One of them was my patient, who after 3.5 years actually had a recurrence that was in field, was very slow, indolent, and I thought, well, this guy really wants to avoid chemotherapy. We went in and re-resected him again. So 1 patient received adjuvant carbo, but then we made a strong push during follow-up for patients not to have any adjuvant treatment, because the whole point of this is to have surgery as your only curative modality. So here are the complications. There were 5 short-term complications. I'm sorry, 7 short-term complications. 5 of them were Clavian Dindo 1 to 2. And you can see these were really minor complications. One of them had an ileus requiring NG tube. 1 was listed as emesis or pain, and 2 were Clavian 3. 1 patient developed chyloscystitis, and 1 patient developed pulmonary embolism. So you can see, in a surgical trial, it's not all walk in the park. Always there's going to be surgical complications, but fortunately the long-term complications were none, meaning that fortunately antegrade ejaculation in all the patients who underwent nerve sparing techniques had antegrade ejaculations with no hernias, no GI symptoms or anything else seen thus far. So short term, so far so good, and certainly long term, it's not too bad. So in conclusion, we think that the Sems trial actually establishes RPLND as a treatment alternative for these patients with isolated retroperitoneal lymphadenopathy up to 3 centimeters, 2-year median follow-up as a systemic treatment-free survival of 85%, overall survival obviously 100%. So it is an attractive option. It's hard to do a phase 3 trial if you think, is the next step of phase 3. You can't really compare this modality with radiation or chemotherapy. You'd have to wait decades to see the difference in complication rates. Obviously, chemo would outdo the surgery in terms of recurrence-free survival. There is a sort of a brother trial or a sister trial to the Sems. My good colleague in Germany, Peter Albers, is running a trial called Prime Test. Very, very similar. He is looking, you can see the differences there, basically looking at quality of life, complication rates, and things like that. He is still accruing to his trial. He recently just expanded it to multiple centers in Germany. So hopefully in the future, we will combine our results. And there's a 3rd trial in London. Dave Nicol in London is running, but those patients are all getting adjuvant treatment, which obviously we didn't want to do. We wanted, so patients are getting RPLND, then getting adjuvant carboplatin, which really defeats the purpose of these patients not getting systemic therapy. So I'm going to move on to management of post-chemotherapy testis cancer. I do want to save some time at the end for question and answer and discussion. So if I move too quickly, let me know. I find surgical history fascinating, and I think it's really interesting that in the early 1900s they thought about doing this. I mean, look at this picture. First of all, it's very low quality. But in 1906, here's a picture of the testicle being taken out, the cord, and then leading to whatever lymph nodes were there at the time. No CT scans. You know, they were probably doing some lymphangiograms or something like this to see these nodes. Really fascinating. Here's another depiction of this incision that's pretty wild, but it was probably extraperitoneal, right? Given the laterality of this, and gave pretty good exposure to the retroperitoneum and all the areas of interest. Probably fairly morbid. So we'll get into other incisions in a little bit. But basically 1/3 of the patients, at least 1/3 who undergo chemotherapy for metastatic germ cell tumors have some form of residual retroperitoneal disease. So the current indication for post-chemo RPLND would be, we'll go through this for non-seminomas and seminomas, talk a little bit about imaging, adjuvant procedures, and then the newer approaches to treatment. So, you know, this is a rare disease, and I'm giving you fractions of fractions. So basically, the volume of disease seen at any one center is not going to be quite limited, right? So there's plenty of evidence that supporting experience is an important component of improved outcomes in germ cell tumors. And you can see this here, and you can see a famous author here who documented the number of RPLNDs done by practicing urologists around the country. And Josh, I don't know if anyone's updated this, but I don't think it looks any different today than it did back then when you published this. But really interesting, you see the number of urologists performing one RPLND sharply drops if you do two, and basically there are a handful of surgeons in the country doing more than 10 a year. And I learned this when I was trying to do the vetting of the surgeons for the Sems trial, and people said, "Oh yeah, I do 30 of these a year," and then we would ask for their op reports and their past reports, and it quickly whittles down to, well, it's actually 6 last year. So these are tough cases. These are long cases, and we tend to, when we do one, we think we've done 4 of them. So but you can see the median number of RPLNDs done around the country is 1, and the very few do more than that. So surgery, the histology really hasn't changed a lot over the past few decades. 40 to 45% post-chemotherapy have teratoma. Same number or distribution have fibrosis in the retroperitoneum, and 10 to 15% have residual germ cell tumor. It's still not really possible to predict retroperitoneal histology based on imaging. And there have been a number of studies trying to establish some form of imaging or radiomics or other to try to determine, because that's really what we want to know, right? If we can predict this ahead of time, then it would help us. So the real issue is we can't really differentiate necrosis fibrosis from teratoma or even viable cancer following induction chemotherapy. This is really a microscopic diagnosis. What about PET scans? It's my pet peeve that so many PET scans are done in testis cancer. It's absolutely worthless except for one setting. The false negative rates are 40% in non-Sems. All teratomas are negative. And it's really, really not helpful. There are significant limitations in detecting very small microscopic disease. So, it's basically extra radiation without any additional information. And seminomas, it does help sometimes determine the viability of residual masses greater than 3 centimeters. But again, we have this issue of a lot of inflammatory cells that are in the retroperitoneal masses. What we use PET for in seminomas is the negative predictive value of 95%. So if it's negative, it helps us. But when it's positive, the positive predictive value, unfortunately, is somewhere in the 50 to 69%. So what are the current indications for post-chemo RPLND? Any patient who has a residual mass greater than 1 centimeter on CT following adequate primary chemotherapy with normal serum tumor markers, we don't do dissections on patients with sub-centimeter masses. There is some controversy, mostly from Memorial, where everybody gets a post-chemo RPLND, but most of us around the world believe that those patients are cured with the chemotherapy alone. If you undergo salvage chemotherapy, almost certainly, most of the time you need post-chemo RPLND. The rates of viable disease and those residuals are much, much higher. And chemo-resistant disease, if you have a growing mass on chemotherapy, and I'll show you a few cases at the end with normal tumor markers, resectable masses with elevated markers that have, had adequate chemotherapy, and late recurrence. And late recurrence is defined as any recurrence that happens 2 years after diagnosis of testis cancer. They tend to be chemo-resistant, particularly if they've been treated with RPLND or chemotherapy to begin with. So most of the, and again, there's an abstract being presented at ASCO, where the Indiana University experience is being updated on late recurrence. And again, you can see the same theme, that surgery should be the mainstay of treatment for those patients. Some special situations, sometimes you have post-chemotherapy, you have a patient who has elevated markers, but they're plateaued markers. And that happens when you have a sort of a cystic mass that's a teratoma that's harboring some elevated markers within it that leaks slowly into the bloodstream. So if you have low but stable markers in this situation, we recommend a post-chemo RPLND. You don't have to wait for that to completely normalize. And you have to follow it. We don't make decisions based on one marker, but rather follow the patient and do several markers to kind of see the pattern. You certainly don't want to do surgery on anyone who has rising markers. And also patients who have very high HCG levels to begin with prior to initiation of chemotherapy often fail to normalize their markers at the end of chemotherapy. So don't be looking for that, perfect, undetectable tumor marker before doing a post-chemo RPLND. The trend and the plateau at low levels is what's important. Now, we talked about management of patients who have had a complete response. These patients do really quite well. This is one report when I was at OHSU with 276 patients combined with the experience at University of British Columbia. There were 161 patients who had a complete response or partial response with less than 1 centimeter lymph node. Most of these patients were good risk, as expected. They would have the good response. Complete response was 115, the partial response 46, but 100% disease specific survival for the patients who were managed with surveillance only and did not undergo a dissection. There was a accompanying article in that issue of JCO from Indiana University, and basically they had very, very similar outcomes. Here you can see the world literature on this topic, the bigger series. You can see the number of patients. The Princess Margaret Hospital experience was presented, but actually never published as far as I know. But here you see the recurrence-free survival, the cancer-specific survival, and the handful of patients who died of disease. Now, many the Indiana patients, 2 of them rapidly recurred after chemotherapy. So the thought was that they would not have been cured with a post-chemo RPLND anyway. This is in juxtaposition to the Memorial data that shows up to a 25% teratoma finding at time of post-chemo RPLND in patients with sub-centimeter masses. But Indiana has a 15-year follow-up on these patients, and they're doing quite well. So this notion of this late recurrence or residual teratoma that may at some point show up, we're just not seeing that. We're not seeing the 25% relapse rates with long-term follow-up in these patients. So again, I think those patients often even don't make it to us because they see the oncologist, the CT scan's clean, and they don't even get sent to us except for some centers. What about adjuvant therapy in patients who have viable carcinoma? So you do your post-chemo RPLND and you find a little bit of residual viable germ cell tumor. Should you give the patient adjuvant additional chemotherapy? So like I said, we find it in about 12% of post-chemo RPLND specimens, but following salvage chemotherapy, it increases to up to 50%. So patients with good prognosis, with complete resection and have less than 10% of viable tumor, they have pretty good favorable outcome without any further adjuvant chemotherapy. That's what the surgery is for, to remove any residual microscopic disease. Now, if you have a lot of viable disease, then that patient really probably needs salvage therapy rather than the 2 cycles of adjuvant further, BEP. Those patients recur very rapidly and move on to other treatments. So again, it's safe to watch patients who have very little residual volume of viable disease following post-chemotherapy. And this is supported by data from Indiana University as well. Little bit about nerve sparing. I think this is something that you need to learn if you're going to go into this business, and you need to learn it really well. These nerves are tiny. They're anatomically very, very distinct in their location and coarse. Obviously, preservation of fertility is of major concern for this patient population. And the extra effort in the operating room is really worth the outcome. This is a non-nerve sparing operation. The patient had a huge mass. This would be a template type dissection, sparing the nerves on that side. But one of the things that Joel Steinfeld says is it a nerve sparing or a nerve avoiding operation? If you completely clean out a patient like this and just preserve the left-sided postganglionic nerves, you may or may not preserve that one single L3, L4 postganglionic on the left. But really what you should be doing is a prospective nerve sparing approach where you identify and actually spare the nerves on both sides if you can, so that you have some insurance. This would be a left-sided template. This is sort of a left extended template. At IU, they sort of stop at the middle of the aorta, and some folks don't do an intra-aortic cable node dissection when the disease is only on the left side. We've always tended to do the intra-aortic cable and some retro cable as well. I don't think it takes that much more effort to do once you clean out this side. This would be a full bilateral template, and taking the IMA, sort of your classic post-chemo RPLND. But this is a nerve-sparing approach. This is sparing a single L3, L4 fiber going down into the hypogastric plexus. This is really all you need to preserve your function. It's amazing that one single nerve can do that. Now, many patients require adjuvant surgery. What we mean adjuvant is additional surgical procedures. And this was just our experience a number of years ago with 85 post-chemo RPLNDs, with 30% of patients requiring adjuvant procedures. And this is very similar in the literature with other series. Most of these are vascular, renal vein, but aorta and cava in several cases, as you know. Nephrectomies are interesting because most of them are on the left side, and it makes perfect sense, doesn't it? The patients who have left-sided tumors, the lymphatics and the masses follow the left gonadal vein, and so the tumors tend to be wrapped around the renal vessels, making it very difficult to dissect. And you can see other sort of adjuvant procedures that are needed. On occasion, we do a neck dissection. I do those in conjunction with the post-chemo RPLND if needed with the neck surgeon. So we do it concurrently at the same time with 2 separate scrubs. Their part is really quite easy compared to what we do. So in order to minimize the patient's sort of time under anesthesia and things like that, is done concurrently, and it's worked out really well. I've got a nice picture of how the 2 teams are positioned so that we're not in each other's way. But typically their part takes less than 2 hours while we're working. The left renal vein is interesting. You can resect the left renal vein and have it drain through its various tributaries, but generally, if that's what's happening, the tumor's wrapped around the renal vessels, and you can't really dissect just the renal vein. It's unusual, but it can be. And in some cases, I have just resected the renal vein and have it drain through its various tributaries and at least give the kidney a chance. I don't graft the left renal vein. I've never done it. I think most of the time it's either the whole kidney is going, or you can just tie off the vein and have it drain through its various tributaries. Vena cava can be involved in a number of cases, and this needs to be recognized. This is a patient who underwent 4 cycles of BEP, and it has obviously a cystic teratoma. But if you look carefully, the cava is actually on the left side, and it contains something intraluminally. And again, if you look very carefully, it's the teratoma that's actually entering the vena cava that happens to be on the left. So the radiologist read this as a left-sided mass with a clot in the cava that is being pushed over to the left. Well, that's not true. This is an actual left-sided cava. And unfortunately, the patient was undergoing warfarin therapy for 3 months before he came and saw me, and they were wondering why this mass keeps growing. So the patient, so this is a 20 centimeter mass, but what it is really an IVC tumor thrombus within the cava. That's a tumor thrombus. So the patient's taken to the operating room, and you can see the left-sided cava there, and there's a tumor within the cava. You get control, and you can see where the tumor actually entered through the the right common iliac vein, and here it is. We're pulling out the teratoma, and all left-sided cavas eventually go to the right, but there's the branch where the tumor actually entered the cava. So these patients do extremely well. It's a teratoma, and obviously it was completely resected. The patient remained disease-free without any further treatment. So here's another case. This is a non-seminoma. This looks really quite nasty. It's a big tumor. The patients had 4 cycles of BEP. There's again another teratoma within the vena cava. The kidneys being pushed, the aorta and the cava are almost nowhere to be found, as this thing is completely elevated. But this was deemed unresectable, and I always say before you deem something unresectable, you really should have another expert surgeon sort of take a look at this and see whether this is doable, because some of these it's a tough case, no question, but is it unresectable? I don't really see it going into the spinal foramina. The bone is not, this is all teratoma. It's a tough case, no question. But look, these kids are in their 20s, and they deserve the very best chance at survival. So we barely got the cava out after hours of dissection and the proximal aorta. And this is one of those cases where everything has to go down to the spine, the aorta, the cava, kidney, and then graft the aorta. But this, as suspected, was all teratoma. Markers were very low, but not completely normal. And this is a teratoma within the cava. Again, so these things can enter the vena cava and go up, and I've actually seen one in the heart as well. So years ago, I started scoping the cava, looking for these things when there was suspicion. And you can see here's vena cavoscopy, and we're seeing a tumor within the lumen of the cava. Helps us decide whether or not to take the cava. Obviously, you have proximal and distal control, and this is really quite easy to do. This is tumor adherent to the caval wall, and you can see me sort of pushing up to orient myself, this anterior posterior, and you can either partially resect this, but honestly, you'll end up with a very small lumen and grafts and things like that. So we generally just do a caval resection in these series. That's very, very well tolerated. And they're tolerated because of this. We published this in JU a number of years ago, showing the venous system mainly being drained through the azygos and the hemiazygos back to the heart. And patients tolerate cavectomy extremely well, particularly because the reasons you're doing a cavectomy to begin with have to do with obstruction and these collaterals forming from the beginning. So I don't graft cavas. I never have. And again, patients do extremely well. There is swelling for sure that happens in the beginning. but it almost always goes away, and there's of course no risk of pulmonary embolism. Aortas on occasion and iliacs need to be grafted at times. Of course, we ask the vascular surgeons to come in to help with these, but the cable work and things like that we generally manage on our own. On occasion, we get these very thin ureters, and you could either wrap some momentum around it and hope for the best, or I was very uncomfortable with the blood supply. You can get strictures, and so the appendix was nearby. We thought, maybe we should bring it over and do that. I guess buccal mucosal graft or something like that might be useful, but I think this was completely stripped, and I didn't want to use a complete ileal ureter. So getting to sort of the back to that extraperitoneal technique, this is something that I started working on about 10 years ago. We used to do these huge thoracoabdominal incisions that were actually extraperitoneal, but obviously extremely morbid back in training. And I thought, well, why do we need the thoracoabdominal incision? I started making it smaller and smaller, and finally doing the opposite of what we used to do from a thoracoabdominal approach, approaching it from the chest down. I thought, well, why don't we start at the bottom up, just like you do in transplant, for instance, and keep developing the peritoneal envelope. And I think most of us are very, very comfortable with the anatomy of the peritoneum, gerotis, fascia, duodenum, liver, and so on and so forth. So initially, I was making these larger incisions to get, and the exposure is identical. There's no way you can walk into the OR and know whether I'm intraperitoneal or extraperitoneal. Eventually, these are these kind of exposures. So this is so the exposure is based on the side of the disease. If you have right-sided disease, I approach it from the right. If you have left-sided disease, from the left, and not both. You only do one approach. So people ask me, oh, do you do one side and then you get extraperitoneal exposure on the other side? No. This is the kind of exposure you get from the right side. And you can see there's the inner aortic cable. We spare the L3, L4 nerve. You get excellent exposure to even the para-aortic areas. It's all about these sequential sort of placement of the retractors and doing some dissection. There's the crus of the diaphragm. And there's a sort of a suprahilar dissection, and you can do a retrocrural dissection there as well. So you can get pretty high, and the incision doesn't have to be huge for you to do that. Of course, this is now a left-sided exposure. Again, you can see that we can easily get retrocable. The left is more difficult because the duodenum and the bowels don't quite, get all the way over, but you don't need to get all the way over and see the right renal vein. All you need to do is get this exposure basically that you're seeing right here. And at the end, this is the most satisfying, where you put the peritoneum back, and don't you wish surgery was like that? You could just peel this back and end up in the retroperitoneum and do your work. But again, this is sort of a picture where, a case where easily we're getting all the way over to the para-aortic area from the right side, and then the peritoneal envelope goes back. It's amazing. The pain, discomfort, nausea, all that stuff is so much related to what you do with the bowels intraoperatively. So I almost feel bad when I'm intraperitoneal these days. I did an ureterectomy yesterday on a horseshoe kidney, and we did that extraperitoneally midline. And it's amazing how different the patients look the next day. So this was just our updated series published a few years ago. We do all of the RPLNDs except for the absolutely massive ones, EP now. All the residents, we call them EP RPLNDs. And you can see that most of these were post-chemo RPLNDs. They were not small. Antegrade ejaculation in 30 of 31 post-chemo RPLNDs, retrograde in 1. And the tumor masses are here. You can see that we had 19 cases with tumor masses greater than 10 centimeters, and a return of bowel function 1 to 2 days, length of stay 3 to 4, median of 3. But like I said, over the past 3 to 4 years, we've actually realized, we can feed them that night. They have clear liquids, regular food the next day, and if they're comfortable, they go home that next day. Here's a good picture of sort of the peritoneal envelope being developed. You can see the bowels through the peritoneum here, and this is the liver basically back here. So this is what I mean by the sequential sort of treatment. This is a large mass in the retroperitoneum. We've peeled the peritoneal envelope over the mass and pulled it over to the other side. And then sequentially, you keep the liver and the colon are basically being retracted upwards, while the duodenum and the rest of the bowels are being retracted laterally. So we're not completely mobilizing the liver off the diaphragm or things like that. It's all intraperitoneal. We just need a retractor up there, and then to deliver the kidney out of that mass to be able to get your exposure. It's we do have some videos, but it's really difficult to capture these in open surgery. But there is a video in European urology. But this is what that patient looked like afterwards. The pathology was an 18-centimeter mature teratoma. He went home in 2 days. So post-chemo RPLND, here's another growing teratoma syndrome with a nerve-sparing approach done extraperitoneally. That's what he looked like afterwards for a 15-centimeter mass. Length of stay was 1 day for this large mass. So nowadays, again, the hospital stays most of them are next day discharges. If you're wondering what these are, and if you haven't seen them, these are on-cue catheters. These are subfascial catheters placed between the posterior rectus sheath and the rectus muscle, and they infuse ropivacaine continually. And just recently, over the past 1.5 years or so, I've started sending patients home with it because I learned that the orthopedic surgeons send patients home with these on-cue catheters, and thought, well, why not? This is just infusing. It's in a pump, and they can take them out themselves. So it's been very useful to decrease the opioids and medications at home. A few more topics here. One's extraretroperitoneal disease. I get asked this question a lot about how, when, and how would you manage this. As a patient who underwent cavectomy, has significant retrocrural disease that's just contiguous with the retroperitoneal stuff. But required a cavectomy, and I promise we we keep a good number of cavas. But this patient, you can approach most of this transabdominally all the way up into the posterior mediastinum, and then come back and do the rest through the chest. Sometimes you get this picture where it looks unresectable again, because it looks like it's just invading the mesentery. But what this is these are cystic teratomas, and they can actually be dissected out. Here's a mesenteric lymph node dissection that we did, shelling out all of these little teratomas out of the mesentery. This is a view that you don't often see, which is the superior mesenteric vein and the branches of the SMA. But just like we're all used to working around vessels, we know the bowel very well, so there's nothing really special to this. Just don't damage these vessels, because they supply a major portion of the small bowel. But this can be done, and the patient can be cured from this as well. Well, in the same token, periportal lymph nodes are sometimes involved for various reasons, but you can do a periportal lymph node dissection as well if you're comfortable with the anatomy here. But again, you need to know where the portal triad is, and you can pull this down and do a completed lymph node dissection around these things. And these are usually teratomas. Look, if they're viable disease, we're not going there. The patient needs additional chemotherapy. This is if I see a cystic mass along with a lot of other cystic masses in the retroperitoneum, I think these can be done all at the same time. Going back to the retrocrural lymph node dissection, I try to do as much as I can transabdominally and not have to go through the chest or do these. I used to do them through a thoracoabdominal incision and get to the posterior chest, but nowadays I try to really split the crus and try to grab them. It's amazing how far you can get just from the abdomen. And we presented this as an abstract a few years ago, but here's a retrocrural mass on the left, this is on the right side. We've split the crus, and you can see it's like a little egg that is sort of crowning here. And these things shell out quite well. You can literally put your finger there. There's no major vessels there, and you can pull these out. And not, if you don't burst them, you can take them out completely intact. So that's my approach. As much as I can, I try to do these through transabdominally, but occasionally there's more disease. You can go through the chest and do a posterior mediastinal dissection. If you're familiar with the anatomy, that this is a funicular through 8th, 9th rib interspace here. We're pulling down the diaphragm. The patient had this large cystic teratoma mass in the posterior mediastinum. Once it gets to the esophagus level and stuff, I think those are best approached with the thoracic surgeons, making sure there's no damage to those very vital structures. But there's really not much there other than the aorta, the spine, and the diaphragm. It's sort of an extension of the anatomy that you're familiar with if you do thoracoabdominal incisions. A few words about GTS. These can become absolutely massive. This is a patient who was 28, had a massive abdominal tumor, had underwent 1 cycle of BEP, and the tumor started to grow, and the oncologist recommended hospice for the patient because there's nothing else they could do. Well, the markers were going down, and the tumor was growing. That's classic. That's classic for GTS. And you can see this goes very, very quickly, but he has a huge volume of tumor within the abdomen, just involving every compartment. So I can't slow down that video for whatever reason, but the point is just to see, obviously this requires a major incision, stem to sternum, and a lot of work as we work compartment through compartment and get, the pelvic, and this is what you hopefully end up with. I actually was planning on doing a nephrectomy, but then realized the kidney is sort of just free standing and all these teratoma masses came off the kidney. So I re-implanted the kidney. I did an auto transplant with the artery and vein, and the kidney actually survived, surprisingly. So this patient went on to have several other recurrences, one in the posterior chest, but this was the major mass, all teratoma. Here he is 3 years later. I've done 2 other operations on him. He had an intra-abdominal mesenteric tumor mass that was very easy to remove. I went there. I did a retrocrural mass, and then I did a thoracotomy on one side and took out another growing 3-4 centimeter teratoma from his left chest. So he's doing really well. So I think, in these post-chemo, in these growing teratoma syndromes, you should make every effort to resect all these as much as possible. Very few words about post-chemo seminomas. We talked about PET scans. There's no role for PET except for this. If you have a 3 centimeter mass, again, we talked about the negative predictive value. This was based on the SEM-PET trial. With 127 patients with metastatic seminoma. The sensitivity was 82%, specificity 90%, but really it was the negative predictive value that is of most use in this setting. If the mass is less than 3 centimeters, look at this, you have no viable disease. So there's no point in getting a PET scan when the residual mass is less than 3 centimeters. So only if it's over 3 centimeters. And so the indications are someone who has a growing residual mass after chemotherapy without marker elevation, or if you have a solitary resectable tissue following salvage chemotherapy to exclude any non-seminoma elements if you're unsure about the initial diagnosis because the patient went straight to chemotherapy. Here's a patient who underwent salvage chemotherapy and has a small residual mass there that's PET positive. We waited and waited. And on one of the PETs, they said definite increase in the size and the SUV of the mass. We thought, okay, well, this is an indication to go back in. Unfortunately, you end up losing the kidney. This is the SMA big dissection, and it turns out to be all fibrosis. So really disappointing that with everything we had, we couldn't predict this, and we thought we're going in there to resect residual disease. We could have easily just watched him, and he would have been fine. He is okay. He's very grateful, obviously, but oftentimes it turns into this. Now, this is a very different picture than the other ones I was showing you. It's a mess. You're resecting cava and aorta, and it turns out, at the end, it'll be fibrosis. So be careful with taking seminomas after chemotherapy. You do want some indication that it's growing, or you're doing this for viable disease. Intense desmoplastic reaction, often requiring subvascular reconstruction, and most of these are necrosis and fibrosis. So this is not a microRNA lecture, but I just want to say this is going to change everything. I think the microRNAs are incredibly useful in germ cell tumors. They're very, very specific. And you can see the AUC here of the specificity of marker RNA versus CT versus tumor markers. You don't see curves like this at all. So incredibly specific. And there's currently a SWOG trial, SWOG S1823, that is capturing basically all newly diagnosed testis cancers, getting their serum, measuring their microRNA, but we're not acting on it. This is essentially a registration trial, and we are looking to validate basically the utility of these markers in testis cancer. So it's a biomarker-based care. But we are working on future studies. We are currently working on an mRNA, microRNA-directed management of clinical stage 2. In the Sems trial, we learned that about 20% of the patients who we thought had disease had a lymph node that was 2 to 3 centimeters on RPLND turned out to be completely negative. So we do have these negative RPLNDs as well, and we'd like to further sort of personalize their management. So we're working on those trials right now. Hopefully we'll get some funding soon and roll those out so that we can personalize our management. So in conclusion, I think we'll need aggressive treatment in post-chemo setting. Adjunctive surgery is often required. The extraperitoneal approach, I think, really offers an advantage in terms of morbidity for these patients. Try to do nerve sparing as much as possible in very, very judicious use of PET scans in the post-chemo seminoma setting. So with that, I'll stop and answer any questions that you may have. Thank you very much.
That was really outstanding, Sia. Can I ask you about the Sems trial? What was your sense from the patients that were enrolled as far as their, we're talking to patients about their choices and what to do. I had a couple of people that went to University of Chicago to enroll in the trial with Scott, and they were all very happy to go, have an RPLND versus radiation or chemotherapy as options. What was your sense from the patients as they were going through this? I mean, I think that's what's ultimately probably going to drive a lot of the decision making is, the patients that are diagnosed, what will they choose to do going forward?
Yeah, great question, Josh. And I think that's a major point. What are patients going to do? That's why I showed you that study with Nick Costa, like, are patients willing to enroll in clinical trials? The answer is yes. It really doesn't take much. I think it's one of, as you know, I'm very interested in clinical trials and try to accrue. And this was one of the easiest to accrue to. And I had patients just coming to us saying, we've heard you have a clinical trial for this. We don't want to have chemo. So the way I presented it was, look, these are the guidelines, the national and the international guidelines for management of stage 2 seminomas. This is what we are doing. We're hoping it's curative in this many patients. And just basically a pared down version of a lay language version of the presentation. You heard that surgery will offer hopefully 70 to 80%. I was quoting them at the time, cure rate. And if you relapse, we can salvage you with additional chemotherapy. It was not a difficult sell. If once the trial ended, I still am doing this surgery. And in fact, I just saw a patient this morning who I did about a year ago. He ended up having a 2C disease. He had 2B going in, a 4-centimeter mass, but absolutely didn't want chemo. So honestly, it's an easy sell, provided you're honest with the patient and have them understand that, look, chemo will give you that 95% cure rate. Surgery is probably in the 80% range, but that's great because so many can avoid that toxic therapy.
Any other questions for Dr. Daneshmand?
So, Sia, this is Bill Catalona. Can you hear me?
Hi, Bill. Yes.
Yes. So, what precautions do you take to avoid the anterior spinal artery when you're doing these high suprahilar dissections and splitting the cruce of the diaphragm?
Yeah, great question. That comes from a seasoned surgeon, because this used to be a concern. So when the point is the suprahilar dissection. So once you debranch the aorta of all the lumbar arteries and you're going in the chest, you should be super careful about doing a bilateral chest dissection of the aorta on both sides. Nobody knows exactly where the artery of Adamkowitz is. That's the artery, the spinal artery that will provide the blood supply to, but it's somewhere up in the upper chest. It's okay to take one-sided, and once we get up there, we're very careful in not dissecting the spinal arteries. Or if you're sending it to your thoracic surgeon, we have a discussion with them and say, by the way, we've taken all the lumbars below, so there are no lumbar arteries to the spine. You have to make sure you do that. And a good thoracic surgeon already knows that. The one we work with carefully. So honestly, we have not had an issue. I know in the IU series, there were a couple of patients who ended up with paralysis, but I think that's when we learned we can't completely debranch the aorta all the way.
Thank you.
Dr. Daneshmand, this is Greg Offenberg. Really wonderful talk. Thanks so much. Since we're talking about technical aspects, I guess a question for you. You know, in the OR, your thought process around, you know, decision-making for when you think of you're going to have to take the aorta or take the cava, you know, often these cases are stuck. And I think, you know, you spend a lot of time trying to peel things off. Can you talk a little bit just briefly about, you know, how do you make that decision of this vessel is not salvageable, I'm not going to, you know, try to keep chewing this stuff off, and how does that go? Because I find that's one of the harder decisions to make sort of in real time of I've tried long enough.
That's a great question. And I think, you know, I don't have a great answer for you other than if I get 3 aortotomies with blood shooting across the room and go, okay, you know, this, or you've, the time where I know this is not right is when you get into a subadventitial plane and the aorta is just completely white, and you're getting into a bad plane, because if you get an aortotomy and that's, setting, then suturing the aorta is extreme. It's like butter. All your sutures will come out. So once you start to get into that plane, it's okay to get out of that plane and sort of leave that aorta alone for a while. But it is very difficult. There are cases where the ones I showed you where the aorta is floating, right? So those are like a little bit more easy decision. But you get into these post-chemo seminomas where you're in and out of those planes. It has to be a sort of a decision. Honestly, the morbidity of an aortic graft in a young patient is not that high. It is certainly longer case and things like that. But if you're going to lose 10 liters otherwise, and you know, put multiple holes in the aorta and potentially even narrow the lumen, I think it's far better than to have a graft in that setting. The cava, well, cavoscopy has helped me a little bit to determine whether there's any intraluminal component of a tumor. If it's really narrowed, I think cavas are easier to know whether or not you're going to take it, because if the caval lumen is narrowed, you can't even see it, dissect it off, then we just go above and below and take the cava, because again, it's so well tolerated. It's the aortas that, and with more experience, I think I've probably kept more aortas as we you know, say, okay, we don't need to take it. We can, you know, dissect off. But it is difficult, Greg. I appreciate that struggle that we all have.
Just to be brief, Katie just left. She had a great time, and everything was really delightful.
Yeah.
I haven't heard